Okay.
My name is Sue Burke and I am a Macmillan GP and the clinical lead for cancer for Warrington CCG. It's really good to be given the opportunity to talk about making a good 2-week wait referral and the value of that. Also with the Cancer DES, we are all requested to assess the quality of our referrals and do an audit and make sure that the referrals that we're making to secondary care are of a really good quality. Make no mistake, a lot of what we said today is going to be really obvious and probably what you're already doing. My hope is that there may be 1 or 2 little nuggets that with the pressures of primary care and everything else that lands on our desks, we've forgotten to do. And we think, oh yes, we really should be doing that. And if we can just use those 1 or 2 nuggets to improve the quality of that referral, then maybe we will make a real difference to our patients and the journey that they have onward. So, it goes without saying we all want the best for our patients. And as I've said, we really shouldn't underestimate the value of a good quality cancer referral. We are tasked in primary care to make a referral the same day and certainly within 24 hours of seeing a patient who we suspect may have cancer. But this haste shouldn't deter us from making a good quality referral. And sometimes we need to just take a step back and make sure that we've given all the information and that we've got all the tests that we need in order for that referral to be speedy once it leaves our desk. We are part of that journey to the faster diagnosis standard of a patient receiving a diagnosis within 28 days. We need to therefore make sure that yes, we don't have a referral sitting around in our tray for a day or so, but that we've ensured that there is sufficient and accurate information available and sent with our referral for a speedy journey to diagnosis within secondary care. Prior to the optimal time pathways and straight to right test, patients often complain that their first outpatient appointment really was a bit of a waste of time for them, that the consultant hadn't told them anything they didn't already know after my consultation and that they needed more tests. And in effect, this was a waste of days in the pathway. And although optimal time pathways have made a massive difference to this, it still happens to an extent, and primary care can really make a huge difference and play a part in reducing the journey to diagnosis, the time to improving patient outcomes, improving patient experience, and it gives us satisfaction that we've been part of a really good job well done. So, it may seem really obvious, but if your patient doesn't have capacity to consent to a referral, they're not going to have capacity to consent to investigations and treatment once they get into secondary care. And we can't just expect secondary care to sort that out. We need to set the ball rolling. We know our patients best. We know their next of kin in all probability. Do they have an LPA for health and well-being? Do we need to be considering a best interest meeting? And if we do, we need to be thinking about that before we even think about referring. It's equally obvious that the referral should be in line with NG12. I would challenge anybody to stand there and tell you every single part of NG12 guidance. It is very complicated. So have it to hand on your desktop. Make sure that you can easily access it. I never found that patients would complain if I said to them, some of your symptoms are concerning me at the minute and I'm just going to check the guidance and see whether I should be referring you urgently. And even showing them the guidance to say either yes we should or no we shouldn't is a powerful tool. Carry the Macmillan Rapid Referral Guideline Toolkit in your bag or have it on your desk. It's a little bit quicker and easier to refer to also. In primary care, one of the things that we are tasked to do day by day is tolerate uncertainty. And it's really hard. And sometimes our tolerance of uncertainty is coloured by experience. So if we've had someone who was outside the NICE guidance but had cancer, then that's going to make us really twitched for a while. However, please don't be tempted to refer 2 week wait just because you want the patient to be seen quickly. Please do stick to the guidance as much as you can. It's there for a reason. And if we refer everybody, it will put the patients with cancer at risk, especially at the moment when there is such demand and such increased demand for capacity for our investigations. Everything with COVID is taking longer, so our endoscopy capacity is really reduced. So it's important that we stick to guidance, but at the same time, GP gut instinct is a massive thing. We've got years and years of experience. So if you're really worried, but your patient doesn't fit into the guidance, have a word with the consultant, ask them what they think you should do. See whether there's a quick way to get them seen, even if it isn't through NG12. Familiarise yourself with all the optimal timed pathway protocols. So ensure the investigations are completed or at least requested at the time of referral. Vague symptom filter function tests are there for a reason. If someone has vague symptoms, how do you know it's not ovarian cancer if you haven't done a CA125? How do you know it's not lung cancer in someone who is a smoker with weight loss, loss of appetite, if you haven't done a chest X-ray? So make sure all the filter function tests for a vague symptoms referral are completed. In the lung optimal time pathway, there are mechanisms in place for chest X-ray and CT scan to be done almost automatically if the chest X-ray is abnormal. But what if the chest X-ray is normal? And we do know that in 25% of patients with lung cancer, the chest X-ray is normal. So in those patients, you have a real strong suspicion and worry that they have cancer, you can still refer with a normal chest X-ray, but please request a CT chest, abdomen, pelvis as you are referring, because it helps to save days in the pathway and shave off some of those days. Similarly, if you've got a raised PSA, exclude a UTI. And remember that if there is any likelihood of a contrast investigation being required, if you can request a U&E so that it's on the patient record, if they haven't had one done in the previous 6 months, that will really help them. That'll shave another couple of days off the pathway. Patient stories are very powerful, aren't they? And I remember being told of a patient who had not really followed the right pathway for ovarian cancer. She'd gone in with dysmenorrhea and dysfunctional uterine bleeding and had had an examination and an ultrasound scan, and the ultrasound scan showed the pelvic mass. She was referred to eat weight, but a CA125 wasn't done because normally you do the CA125 and that triggers the ultrasound, but this had happened the other way around. And therefore she was delayed in secondary care because that CA125 was needed in order to determine the risk of malignancy of that pelvic mass. So try and ensure that you have really thought this through carefully and all the investigations are either done or are ordered so that it shaves days off in the pathway. It's front loading of these referrals and it really does help further down the line. Please use the correct referral form for your area. There are a lot of old referral forms sitting around on GP systems, some of which are still using the old guidance, not the 2015 guidance. So have a purge and make sure you're using the correct referral form. And if your area uses clinical templates, which are really useful in having mandatory fields and prompts that encourage you to make sure all the investigation and all the information is correct, then use those as well. Make sure that your history is accurate, comprehensive and complete. So detail all the symptoms that are there. Don't just tick the boxes on the nice pro forma, and talk about how long they've been there. Are they getting better or worse? And are there any associated general symptoms, your systemic symptoms of poor appetite, weight loss, fatigue, anemia, etc. Consider mentioning risk factors. So a family history of cancer at a young age, whether they're a smoker, their alcohol consumption and environmental and occupational exposure. This helps our secondary care colleagues to prioritise these patients. We need to make sure we mention the comorbidities. The associations, the liver cancer and cirrhosis, the ulcerative colitis and colorectal cancer, the diabetes and uterine cancer, just to name a few. Mention those, again, it helps to prioritise. And if we give a good indication of our patients' comorbidities, it helps secondary care to determine their fitness for investigation and treatment and any special precautions that are needed. So if a diabetic needs to starve, they need to be aware of that, whether there is a cardiac or respiratory history, and if a patient has dementia and may need some additional support. So do mention all that. And if you possibly can, include the WHO performance status or Rockwood score as a routine. It really does aid MDT discussion and a treatment plan. I remember attending a colorectal MDT meeting, and the commonest question that was asked was, well, how fit is this patient? Because very often, most of the members of the MDT meeting had never met the patient. So it's really important for us, who know our patients well, to paint that picture of our patient so that our secondary care colleagues can make the best decisions for them. List their medication, usually that pulls through, but perhaps remember to ask patients about any OTC meds that they've taken recently and anything that might adversely impact some of the tests, so iron and vitamins that they may have taken if they're having full blood count and iron studies done. I've often heard clinicians and colleagues say to me that they're not going to do an examination which would not change their management, so there might be no point in doing an examination of a patient who has clear NG12 symptoms of colorectal cancer, for example. However, most of the optimal time pathways now operate a straight to right test, and we cannot determine what the right test is without those examination findings. So for colorectal cancer, if the patient has an abdominal mass, that right first test would be a CT colon, usually. If they have a rectal mass, it would be sigmoidoscopy. If they have no abnormal examination findings, it would be a colonoscopy. If we do not undertake this examination in primary care and give that information, then optimal time pathways are inoperable, and the patient will have a longer journey to diagnosis. We also, of course, need to do some examinations if we're thinking about doing the FIT test. So again, it's really important to make sure that we've done an appropriate examination and recorded that. I've said before, raised PSA, have you excluded a UTI? Please do that. Please say that you've done that. And finally, have you checked that your referral form is fully completed? Are there any glaring gaps in the information? Are the patient contact details correct? If the patient's moved house or changed their phone number and not told you, then the hospital won't be able to contact them, and neither will you when the hospital gets back in touch with you and tells you that they can't get in touch. So it's a really good opportunity to just check that the contact details you've got are recorded and are correct. How have you found it communicating with this patient? If you've struggled, it's very likely secondary care will struggle. If they need an interpreter, if they have hearing difficulties, those kinds of things need to be made apparent to secondary care so that things can be put in place and steps can be taken to minimise any delay caused by this. Have you actually told your patient that you're referring them along a cancer pathway? It's not a secret, and they're going to need to know at some point, so you might as well be the one that tells them. They need to be prepared. They need to possibly think about taking somebody with them, because you know as well as I do, as soon as someone mentions the word cancer, everything else is just forgotten in a fit of despair and anxiety. And if you've told them that there is a small chance they have cancer and therefore you're referring them along this pathway, they're likely to give priority to the subsequent appointments for investigations, tests, to see a consultant, to have a telephone appointment, and they're going to give that a higher priority than maybe their hair appointment or other things that may be pressing to them at the time. The use of the 2-week wait patient advice letter, called a Minnie Mouse letter in some areas, it's a nice gentle letter which basically tells the patient what you've discussed with them. It goes over what you've discussed. It tells them what will happen next. It gives them links to support like Macmillan, who could support them whilst they're waiting and anxious for these appointments. And finally, have you safety netted the referral? Safety netting is hugely important at all points in the patient journey and also at the time of referral. The time that we make the most mistakes in primary care is when we're distracted, when something happens, somebody knocks on the door, there's an emergency, and we can easily forget to do something. We might forget to dictate the referral, we might forget to send it to the secretary might forget to send it to the hospital. Are there safety nets in place at every point in your referral process? So hopefully that will just have jogged some memories and will cover some of the really important and key things in making a good quality referral. And the final point really is to say again that you are painting this picture of your patient. You may have had a relationship with your patient for many years and you know them well. Secondary care colleagues are meeting them for the first time. Paint that picture so that secondary care colleagues can really make sure that your patient has a smooth journey to an early diagnosis or to exclusion of cancer, which of course is equally important. Thank you.